All right. Jim, you're up.
Great, thank you. And we are going to get started on time here today because we have a tight schedule and some great presenters. Welcome. I'm Jim Theophilus, the Executive Director of NorthStar Advocates, and welcome to the March 24th Bridge Coalition meeting. Invite you to put your name and pronouns and the organization you represent in the chat. And just a reminder, part of NorthStar's mission that we have fully embraced is really supporting those young people who are surviving and at times thriving at the intersection of unaccompanied homelessness and the behavioral health crisis that we have here in Washington State and across the country. And again, I welcome you all here, and in particular, my good friend and one of our champions in the legislature, Representative Davis, Lauren Davis. And with that, I will turn it over to Mayana.
Hello. Yeah, so before we talk about like introducing our first speaker of the day, I just will as I have during the last few meetings, I will briefly go over what the bridge is, and just the general goals of this space for a refresher, and in case there's like anyone new with us. And it will also serve to help everyone here understand our shared goals as well as the purpose of conversations we'll have today. So with that being said, the Bridge program focuses on youth and young adult exiting inpatient care, which is defined in this case as the carceral systems, mental or behavioral healthcare facilities, and rehab facilities. We have this focus because the data is clear that there's a high disproportionate rate of youth and young adults exiting these systems and consequently experiencing homelessness due to a general overall lack of support and resources post-care, but specifically largely accessible housing. So, with that context, the bridge more concretely has three purposes. One, information and resource sharing, like this meeting today. This first purpose really aims to communicate with our community partners like you all to ensure that we're all more informed with up-to-date practices and research regarding the varying forms of support for youth and young adults from these systems. And we also share updates and bring information that we have to you all in an effort to community build. The second purpose is developing what we call the return to community planning, which is what we've named the discharge framework that we use for the bridge housing when youth and young adults are ready to return to community after having spent time at the housing. This framework was and is informed by youth and young adults with lived experience of homelessness and these systems to ensure that we're not just another repeat of their frequent systemic discharges into homelessness. And we call it the return to community plan rather than discharge because this is more intentional language that better reflects what we really want to do, which again is have youth and adults return to community rather than homelessness. And then the third reason is advocacy. That's how we created and maintained the bridge housing as well as these coalition meetings. And we continue to engage with youth and adults for input on all the work that we do. And this coalition is a shining example of how advocacy is central to everything that we do. So thanks for listening to my spiel. And I believe I'm passing over to Sarah now to introduce our first speaker of the day.
Mayana, thank you so much. And I am going to do a little bit of housekeeping real quick. Zoom did an update, so I actually want to make sure this is getting recorded. So I'm just going to stop us for 1 second and just double check because I would hate for us to miss this. Okay, we are good. Sorry, always updates. I'm so excited. I get to introduce the next speakers. We have the Harborview Community Heart Failure Program, and they are going to do a much more in-depth overview of their own programs. But I wanted to just quickly say why we invited them. I've had the privilege and opportunity to work with our young adults on the advisory committee with NorthStar Advocates, in particular Sierra, who will be co-leading this presentation. And a lot of the topics that all of us are talking about are individual care, trauma-informed care, but what do these things actually look like in practice? And when you hear Sierra's story, you're going to understand why we invited this nurse team to come and talk about their program and the principles that they've been able to embed and just the life-changing work that they're doing. So big shout out to Sierra and this team. This really is young adult chosen and driven. And so I'm just really happy to turn over the floor. And with that, I'm going to go ahead and share their presentation and pass it over. And can everybody see my screen?
Yep.
Perfect.
All right. A big thank you to Sierra for inviting Jamie and I today. It's we're just grateful that we're in her life. This is the Harborview Community Heart Failure Program, and Jamie and I will be talking today, although we have many um, folks that are part of this program. So I'm Kate Smith. I'm a nurse at Harborview, been here for 25 years.
And I'm Jamie Peckin. I'm a nurse practitioner. I've been at Harborview for about 13 years. Kate and I started this program in 2021 as a part-time pilot, and based on its success and the need, it's grown into a full-time program, and we now have a pharmacist, another nurse, and two cardiologists who come out with us as well.
Next slide. So this is us, although we've added another person, so we'll have to update our picture. But we are a group of multidisciplinary group. So we have nurses like myself, and then Jamie, a nurse practitioner, cardiologists out of Harborview that are trained in heart failure, a pharmacist, a part-time pharmacist, and a back staff, our lovely Zoli. And we go out into the community 5 days a week. Next slide.
So the purpose, this is our mission statement. This is at the top of every note for every visit that we see. The purpose of this program really came from what Kate and I were observing working in a hospital setting where we were seeing many people who would be admitted for conditions like heart failure multiple times, and then they weren't making it to clinic and they weren't able to access any kind of outpatient care that they needed to stay well. And by meeting with these people in the hospital and trying to learn more about their needs, what we came to understand was that a major barrier to care for many of the folks that we see is that the hospital really is not a safe place and the healthcare system is not a safe place. And so we decided to bring care directly to the patients. So we will go see our patients wherever they would prefer to get their care. That can be a street corner, an RV, permanent supportive housing, a library, a Starbucks, and we really aim to provide full service heart failure care to people, including cardiac ultrasounds, lab work, EKGs, wherever people feel most safe and comfortable getting their care.
Next slide.
Next slide.
So, who do we serve? Well, I mean, heart failure is our focus, and no one really needs to understand the particulars of heart failure to understand what we're doing out there. But we do focus on a specific type of heart failure. And we're also really hitting those patients that are not making it to any kind of outpatient follow-up. With heart failure, you really need a good support system to keep you stable and staying out of the hospital. It's a pretty devastating diagnosis. And we are seeing in our age now a lot of younger people getting heart failure due to a lot of drug use or just the nature and course of their illness. So these patients are not making it to any kind of outpatient facility. And then the big piece that we really wanted to focus on, being Harborview, being a safety net hospital, are folks who are having issues all over the spectrum. So we see people that have mental illness, substance use disorders, a history of homelessness, or currently homeless. And that's a really different way to approach care for heart failure in cardiology. It used to be that, well, if you had any of those issues, that you probably were not going to get any care. Like you're out of luck. So we really try to focus on folks that are having other issues, social issues in their life. We also try to see people that are in and out of our hospital. As you can imagine, when you're sick and living on the street, you're in our ERs a lot, you're coming into the hospital and quite frequently probably leaving because you need other things, you have other priorities, an animal that you have to take care of. So things like that. We see people being Harborview, whatever their English language may be not the best or their immigration status. I mean, there's really no barrier to us coming and seeing them. And then maybe not for this group, but there are like some people that we can't see if they're in a nursing facility or if they're on dialysis or if they're really sick with something called home inotropes. But that's our referral criteria. And I'm also just going to say, we used to have it open to everybody in the King County area. And because it's become popular and we're such a small team, we've had to really focus on patients that are at Harborview or have been seen at Harborview. We have ways to work through that, like we'll just come on down to our ER and hopefully we can meet you. But it is a Harborview patient that we're seeing right now. Next slide.
And just to add to what Kate said, a piece of context that might be really helpful is that in the last about 10 to 15 years, we've seen people developing heart failure much younger, in their 20s and 30s and 40s. And there's been a strong association with stimulant use, particularly methamphetamine. We think it has to do with the way that methamphetamine is now being produced. And we also think that there may be a genetic component. Cardiology being the field that it is, there had not been a lot of research into what this is and why it was happening until recently. We're now part of a group that's trying to better understand this. But because of that, our population skews very young. And about 80% of our patients have a stimulant component of their heart failure. So it looks a little bit different than what people might expect for a diagnosis like that. So what do we do when we see a patient? The first and the most important thing is we listen. We try to just listen to what their concerns are, what their fears are, what their symptoms are, what they want from their care. Maybe what the hospital or a doctor thinks should be their goal isn't their goal. And we really want to make sure that we're prioritizing our patient's goal. So sometimes we won't even touch a patient till the second or third visit. We won't get vital signs. We won't talk about medications. It's really about making sure that we understand what their needs are and that they are comfortable with anything that we do, that they're in control and we are providing recommendations and support, not leading the care. And from there, we really strive to give people access to care that everybody should have access to, but that a lot of people don't. So that can involve ultrasounds to see how well the hearts are squeezing, EKGs to make sure your heart rhythm's normal. We do blood draws, and now we can actually get results in the field. Heart failure, like many conditions, is medication dependent. So without medications, people get very sick. They can feel like they're drowning or actually can drown in their own lungs. They can get very swollen. They can't breathe. They can't walk. It's very, very distressing and tends to be very manageable if we can make medications a safe and reasonable option for people. That can be really challenging depending on your experience with medications or your living situation. So we spend a lot of time trying to figure out how we can make it easier to take medications, whether that's streamlining them, making them simple, helping people store their medicine safely, and giving them small medisets like on a weekly basis that they can take with them, and trying to do whatever we can to remove those barriers. And underneath the core of all of this is harm reduction and trauma-informed care. We make a really big point to not make our care contingent on anything from the patient. You don't have to be sober. You don't have to want to be sober. You don't have to want to treat mental illness with medications. That doesn't work for everybody. Really, our goal is the patient's goal, and that's really kind of the fundamental thing we try to live with. And then we really try to make our care trauma informed. The hospital and the medical system is a place that can be a source of so much trauma and so many really horrible experiences for people. And so we try really hard to be an advocate, and make sure that when our patients are coming into those spaces, that their needs are understood, that their wishes are represented, and that we try our best to make it a safer place. Next slide.
So a typical week for us, as I mentioned, we're out 5 days a week in the field, and we see about 6 to 7 patients a day per team. We started off with just one team a day, and we now actually on a Tuesday, currently today, we have 2 teams going out, and we'll be adding even another cardiologist by the end of the summer. So we're growing, which is exciting. But usually we have a provider and then either an RN or a pharmacist. So we go out in pairs. And the patient that we see could be somebody that's pretty sick that we have to see once or twice a week. So we're pretty nimble. You don't have to wait like 6 weeks to see your cardiologist. and or they could be pretty stable. And so we see them like every other month and we just check in and make sure they're doing okay. So we really have the ability to be flexible. We have about 90 patients we see currently. We are getting about 5 new referrals a week. A lot of them we do have to turn down just because they're coming from out of Harborview or the patient hasn't actually failed an appointment yet, which is just a tough one for us. But we've made our referral criteria so tight just because we're such a small team and hope in time that we can keep opening up. I mean, this was a very different way of providing care for Harborview and their clinics. So we we are constantly up against changing the paradigm. And so our team is still small with hopes that in 5 years from now, our referral criteria could be much, much bigger. Next slide.
And so we try really hard to serve a large area because, as we all know, downtown areas are getting harder and harder to stay. And so many of the people that we see live north and south. We go as far north as Shoreline, which is actually where I'm headed in the car right now. I'm not driving. And as far south as Burien. We used to go all the way to Auburn, but kind of along those lines, Harborview has asked us to kind of rein in our service area as we get bigger and have more patients to see and more needs to fill. Next slide. Oh, that's it.
That's it.
Yeah. So that's us. That's what we do. We would really love to make this a care model that exists for lots of different kinds of care, a lot of different kinds of healthcare. And we are working with some partners to see if this kind of care can be expanded to other areas to make other services more accessible for people as well.
And we can take questions.
I have a question.
Yeah.
Oh, I know you.
Hi.
Hi.
Hello.
How are you?
Good. Hi.
You've had to listen to us, blah, 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 quite a bit.
The types of medications that you're utilizing, maybe you covered it, maybe I missed it.
So we for heart failure specifically, there are 4 major types of medications that we know if we can get people on at least small doses of those medications, they actually have a chance of recovering their heart function, so their hearts can actually go back to normal. And this is particularly true if there's a stimulant associated component of their heart failure. So it tends to respond really well to medications, even if they are still using. So that's our primary goal. In the course of our work, because we become an access point for healthcare for a lot of people, we wind up managing a lot of other medications for other health conditions. And then a huge part of our work recently has become trying to help people with safer use or harm reduction. So we work really hard to help people access like Vivitrol or naltrexone and Sublocade, Brixadi, and work really closely with our community partners to try to help people have access to those medications. So we do a lot of medication co-management outside of heart failure just because of the nature of the work, but that's what we were supposed to be doing when we started.
And then are you able to have the medication, prescribe it and pick it up, or make sure they get it?
Yes, we do. We can send it to our pharmacy, make sure that they have financial assistance to cover the copays, pick it up, deliver it to the patient. We have a locked pharmacy of our own. So if they prefer us to hold on to their bottles, if they feel like that's safer and the medicines that we get a time, we can do that for them as well. So yes, it's not just like prescribing it and saying, oh, okay, go get it. A huge part of it is saying, how can we bring them? That's part of why we have a pharmacist with our team, is because we do a ton of bringing medications to people, filling medisets, because medicines can be super complicated. And I mean, we've laughed at our over 50 years of experience between 3 of us, and we struggle to fill the medisets sometimes. So I don't know how we expect other people to manage something like that. So yeah, we try to, if a patient wants to manage their own medicines and they don't want us to touch them, we will respect that and absolutely let them do that. If they'd like help in those areas, we're happy to do everything up to literally handing them a filled mediset and every week and letting them take it from there if they want.
Well,
and a lot in between.
Obviously, the broader question about what is inside the things that are being sold as methamphetamine or clear. That's a broader question. Not sure if you're going to cover that. I appreciate it. We're all working on that one, but thank you.
Yeah, yeah,
Yeah.
it's a challenge. And it's sad. I think it's people who've worked in the field and worked in the community. We've all known this for a while. Like something's wrong. Like there's something in the meth that it's really hurting people's hearts and other parts of their bodies. And there needs to be more research into what this is and how we can help.
Yeah, quicker, faster. Like
Yes,
that onsets of things are quicker and faster. Yeah.
Mm-hmm.
exactly.
Mm-hmm.
Appreciate you.
Thank
Thank
you.
you, Johnny. Any other questions? I will just add that because it sounds like there's with the work that is represented here today, there's a lot of focus on youth and changing outcomes. And I think Jamie and I are the biggest gift that we've had with our program is helping a patient that the system, i.e., Harborview or um, just cardiology in general, would have typically said they're going to die. There's nothing we can do. It's a bummer that they didn't, have a different outcome or born to a different family. So very like, there's just nothing there. We've been able to kind of show our colleagues and show the system and ourselves through our patients that you can change and you can get care and you can have a good life. And that's been huge. And I think it's really important for everybody to feel like that there's possibility and hope. And if there isn't, Jamie and I have been a part of many deaths, and we've advocated for our patients if there's nothing left, but we haven't just kind of walked away saying that there's nothing we can do. So I think that that's been our biggest gift, and the person that's going to talk next is definitely an example of that for us because our patients teach us more than we can teach them. And knowing how hard life can be, it's pretty amazing that somebody can kind of walk that hard path and still have a heart failure diagnosis and survive and thrive. So it's been an amazing journey.
Jim,
Yeah, can I ask?
yeah,
Yeah, thank you. And I'm sorry if there's a delay between the talking and all that. But again, thank you so much for what you do every day out there on the front lines. And you talked about youth and it being limited to Harborview, but it also, I guess I've been one that worries about geographical justice.
Hmm.
And I'm wondering, are there other teams around the state that do what you do? What's the challenge around replication? Um, we're blessed in King County, and there's folks
Yeah,
who
I
have
mean,
needs
Yeah.
outside of King County.
yeah, I think that that's probably a huge issue. And just let's just take it out of King County, but the whole West Coast. We are the only program in the nation that helps this type of patient with this type of heart failure in this kind of
Longitudinally.
way in
Yeah.
longitudinal. But I mean, there are a lot of street medicine teams, but there are none that we know of street cardiology teams that are helping this type of scenario where you've got so many social determinants of health up against a patient, and then on top of it, they're very sick. So we hope that in time, other hospitals will adapt. That's kind of what we're working on now is getting enough data to show that we are preventing hospital stays, all the money pieces that a hospital needs to see to make a program viable.
And I think one of the things that actually has been a big point of education for me is how little the healthcare system kind of understands that the the things that are barriers to care for a lot of patients, they don't go away just because you were able to make a connection, make a relationship, get somebody medications. And so something that we are kind of constantly trying to educate our own colleagues, administrators on is that this isn't something that goes away. So, you know, the the gift of this program is that we can follow and have followed people for years who never do feel like they can safely transition back to clinic-based care. And that's a really hard pill for a lot of healthcare systems to swallow. They kind of feel like, well, you fixed it, everything should be better, which is possibly the most trauma uninformed approach I can think of. Um, and and then the hard part is that money talks, and we justify our existence through cost savings. So by showing the hospital that we are preventing hospital readmissions and we're preventing unnecessary hospitalizations. But the math on that is much more complicated than a procedure where you can make a bunch of money by putting a new valve in somebody and sending them home. So those are bigger structural barriers. And I mean, I like laugh, like this is going to wind up like, I'm going to wind up in, all I wanted to do was go help people with heart failure. You're going to wind up in Congress, like trying to make people change how they provide healthcare. So it's a bigger issue, but I think part of what we feel like we can do on a smaller scale is develop a reproducible model. So we've worked really hard on doing that and publishing it, and then never losing like our core identity of the work, like why we are doing it and what it means to us, but also at the same time being able to show that it is a cost-effective way to provide care, because it is so different than the kind of 15-minute appointment streamlined care. And it is actually cost-effective. It's a very, very useful way to provide care, but that involves a lot of cultural change in the healthcare system.
Thank you so much. And I am gonna, and I know you, and again, you're literally traveling to go meet a patient, and I know you guys have it pretty tight. So I actually want to invite, and Katie, you did such a great introduction. I want to invite Sierra if you're ready, so they can maybe hear part of your story. And then Foundational Community Health with Healthcare Authority actually had to cancel today, so we have a lot of room with Sierra afterwards to continue this discussion. So with that, I'm going to ask Sierra, I'm going to turn it over to you. And again, take your time. We don't have a time.
Cool. So, everyone, my name is Sierra Phillips, and I use she, her pronouns, and I'm just going to go ahead and briefly share my experiences with this program. So, my story with heart failure. So the date was March 10th of 2022. And at this point, I had been to Swedish 9 different times over the last 2 years. And each time I'd be diagnosed with having cellulitis of legs and was given like 3 to 4 days of IV antibiotics and then discharged and told to finish up the week-long course of antibiotics. I'd feel better for a short time, and then I'd be back to feeling really cruddy. Growing up with a hypochondriac mother who would rush me to the hospital for the slightest thing created a fear in me to admit that I may be sick. And this fear has led me to wait until I'm pretty much near death before I actually go into the emergency room or go to the hospital. By the time that I had gone to the hospital this time, my swelling in my legs was the worst I'd experienced. I couldn't bend my knees. I remember like trying to change the tire or fix the tire of my RV at the time, and like I had to throw my pillow onto the ground and just kind of throw myself down onto that pillow and throw myself back up in order to like do anything. I was struggling to breathe, and something just didn't feel right. And one of my really, really good friends suggested that let's go and try a different hospital. Let's not go to Swedish again. Let's try another one of the hospitals here in Seattle. And so we ended up going to UW Montlake. By the time we managed to get there, it was as if my body had given up. So every part of me that was trying to be strong, trying to hold it together, just kind of gave up. I was incoherent, had a pretty high fever, and was unable to actually even walk myself in there. Initially, again, they tried to push the antibiotics and saying yet again it was cellulitis. And I remember feeling really defeated at first. However, thankfully, the same friend, when she came to visit me the next day, she advocated and helped me kind of advocate for myself and asked that they do more tests. Those tests found that I had pulmonary arterial hypertension, which is high blood pressure in the arteries in my lungs. This high pressure results in a decreased flow of blood, and that in turn has caused my heart to overwork, resulting in heart failure. I remember getting this diagnosis and being really confused and asking like, why me? And I remember my friends asking the same thing. They'd point out that I didn't use needles, that I didn't use opiates. So why was I the one that got sick? So similar to like how Jamie and Kate were mentioning earlier, that like stimulant use is a very common thing for folks. But it's not really necessarily known a lot of people aren't known about it, and it's not totally talked about. So it's new to a lot of us, and so getting this diagnosis wasn't the fix for me, though. I like it was a start. At that point, I still continued to use, wasn't taking my prescribed medications, and wasn't going to my appointments. I had another 3 or 4 hospital admissions after that, and would get a little better each time, only to decline yet again. And then in November of 2023, um, I was sick yet again. This time, I couldn't walk 50 feet without needing to be placed on oxygen. I had pretty much isolated myself and my dog in my RV, and pretty much accepted that that I would likely die there, and I was okay with that. I had burnt my hands so severely a couple weeks prior and was unable to open my medications. And thankfully, though, a friend came to check on me. She took one look at me and she told me that she wasn't going to leave me there. She wasn't going to let me die, and that I had to go to the hospital. Like I had no other choice. This time I had spent 2 weeks in the hospital there, and when I got out, I was ready for a change. I ended up walking away from my RV at the time and going and staying at the tiny house village that I was in full time. And at this time, that's when I got connected with Kate and Jamie. They started showing up in my tiny village weekly. They did the medication management. They helped me fill my Medi-Set. They brought me multiple different types of Medi-Sets, from just simple little weekly ones to real big ones to I currently have an alarm one that goes off and rotates for me as well. They showed up for me and really gave me the support that I needed. They've been such a blessing for me, and they've shown up for me even when I haven't shown up for myself. I've gone from meeting them weekly to I believe we're now once a month now, I think, is where we're kind of doing now, just about, which is really cool. And I think what they're doing definitely needs to be replicated. I think it's hilarious that you guys made the connection that you guys did with Johnny, because I actually prepared in my little spiel that I prepared here. I've said for years that there needs to be more Johnny Otis. But I now believe that there also needs to be more Jamie Huckins and Kate Smith as well, because of what you guys do. And I talk about my health conditions often with people so that others can get the help that they need too. And that I just want to end this with a huge thank you to both Kate and Jamie and the rest of the team, and to say that you guys are absolute legends. And I'm so grateful to have you guys as part of my care team.
Thank you, Sierra. That's lovely. And all the work that you've had to do. I mean, just having to trust 2 strangers walking up that day. I remember sitting in the community space of the tiny village, was freezing. And I think you actually syncopized that day. You fainted, remember?
It wasn't that wasn't the first appointment, but it was
the second one.
Yeah.
You were very sick. So
yeah, you guys, the first one, I know you guys had tried to show up at my RV for the first one.
That's right.
And then you guys showed up, and I had already I didn't have a phone of my own or anything at the time, so I just had kind of walked away, and you guys were kind of okay. Thankfully, my reach case manager was in contact with you guys too, and she was able to figure out where I was at. So yes.
Yeah. And the cool thing, I think, for our program is that we get to watch people go through their different spaces. So, from the street or RVs to tiny villages or shelters, then into an apartment. And that is just, all that work you've had to do. It's amazing.
Yeah. And I mention all the time, I think it's really cool that you guys can meet the people where they're at. And it doesn't matter where they're at. It's really cool that they can be wherever that is for them and what they feel is safe. Because like I said, it took me years and years and years to really start regularly going to my appointments and doing all of the things. So it's nice to have people showing up for you, even when you can't yourself.
Thank you so much. And that is exactly what trauma-informed care and individual approaches is supposed to be. Sierra, exactly what you said, how do we show up for people? Like I said at the beginning, I did a short intro so that we could go through, but Sierra and I've had many conversations about bringing awareness to young adults and chronic health conditions. And I was so struck because I was an opioid user, I was an IV heroin user, and at 21 was diagnosed with hepatitis C and went through a similar journey of trying to get access to care, and it was so overwhelming. And then listening to Sierra with the stimulant use and just how heavy and the numbers of stimulant use, like this just seems like it's going to be a chronic issue, and it already is. So I cannot thank all of you enough for coming together and doing what you do. And Sierra, it's been such a privilege working with you and your presentations and your advocacy and your voice. And we will be doing more summits on these topics. And Sierra is a large part of that, right? How do we create more culturally and developmentally responsible systems? So I just really want to thank you. And I know our guests may need to leave. Stay as long as you want, leave whenever you need. I do want to open it up if anybody has any questions, so we can kind of continue this conversation.
I don't really have a question, just more of a statement. I just wanted to say hearing that story gives me encouragement because I had a similar story too. I was a fentanyl user for about 9 months and I got really deep into it, living on First Street, like anything I could to get to that. So, it's a long process for everyone, I think, going through that kind of stage of addiction and just 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 everything that involved with that. So just hearing more about it, saying, more people feeling like they're not alone is just always just encouraging. I just wanted to say that.
Thanks so much, Josh, for sharing that. I feel the same way. Any other questions or thoughts? I know big thank you to Sierra and the team. I'll give everybody another minute or two, and then we'll continue on with our agenda.
And I'm so sorry, I have to hop off. I have to go see a patient. So I thank you everybody for letting us come and join your group today. I really appreciate it.
Thank
Bye,
you very
team.
much.
Yes, thank you so much. And I realized that we hadn't left our contact information, but I could maybe email it to you, Sarah.
So that's what I was going to say. If you email that to me, I'll put together meeting notes. And again, this will be on our website, but I'll make sure everybody has the contact information and
Sure.
the presentation.
Yeah, great. Thank you so much.
All right. Thank you. Okay. And with that, if there aren't, oh, Jim, I see you coming off
Can I
mute.
just say one real quick, as a side note, I'm not the only one that is annoyed by the AI note tracker or whatever people are texting me. Can we get rid of that?
Yeah, I don't know how that comes on. So let me
Is
try.
that still Charles? Charles does that at
Yeah,
all the meeting. I always know what meeting he's not going to be at because I see
I
that.
know. Hold on. Let's delete this. Yes, it's
Just
deleted.
give it one try, and if it doesn't
Yep.
work, that's fine.
Nope, I was able to just delete that from up here in the AI and not share it out. I don't know who Charles is either, but Charles AI is a lot of our meetings. Thanks, Jim. Okay, well, if there aren't any other questions, I do again, Sierra, thank you, and I actually get to pass the meeting back to you for your specific role during these coalition meetings. So the meeting is back to you.
Here's that. There you go. Yes. Well, thank you for everyone for letting us share that. And I really, like I said, it's very important to me, this talking about medical stuff and whatnot, especially within this community of folks. So yeah, I guess I'm gonna go ahead and just kind of go to the next thing. And so the next thing that we're gonna move into is gonna be some just with some feedback about what's going on in the houses right now. And so with that, I'm gonna go ahead and turn it over to our West Side house forensic. So, yes.
Thank you, Sierra. Hi, everybody. Hope everyone's having a wonderful week. Yes, we are very excited that we are going to finally open the second house. We have officially telling everybody a date, which is going to be Monday, this upcoming Monday. And so we do have a wait list, and I think I mentioned it on last meeting. We do have a wait list. We do have a couple individuals right now that are going to possibly go into the second house. So we are very excited. But I will encourage everybody here, if there's any, we're getting a lot of phone calls from many community partners, everybody just wanting to know more about the program. I feel like every time we have this meeting, we get more calls and calls, which is wonderful. But yeah, if anyone wants to call and or recommend or refer someone, we're doing phone screening, placing people on wait lists, and trying the best we can to get people in here as fast as we can. So yeah, happy to be able to provide that update for the second house, which will house another 5 youth. As far as the current house that we have right now, um, it's we are in celebration mode because a lot of the youth, or I would say most of the youth, have jobs right now. Um, so we're having to like change the times we meet for groups and this and that, chasing them around because they're so busy, which we're really proud of them. They all have employment, they all have housing lined up for them through different venues, whether it's coordinated entry, their own apartment. I mean, it's honestly very nice, very, very nice to see what this group of young adults that we have. We're very impressed, very, very proud of them. And they're also, while maintaining those areas of employment and housing, they're also trying to work on their mental health and just continuing to engage in the SUD services that we have and many other groups that we offer. I think that would be the main update for me. I think, like I was mentioned in every meeting, just some feedback and some of the things that we're seeing. SUD continues to be, of course, the biggest challenge for them. Being out in the community is really hard, and it doesn't matter if you have a couple of achievements, whether they have employment, a lot of services working for them, a lot of support. It's just really hard. So it's a struggle for some of them to navigate those challenges around SUD. So we're trying our best to support them, but we really do see that they're really trying and ultimately making that decision to stay sober, regardless of the many things that are out there in the community when they have to go to work. We do have a youth that's out there and working in Seattle. So that's a drive for him. That's a huge time with public transportation. So of course there's a lot of temptation. So we're really proud of him for being able to get to work and come back and try his best to stay clean. I think that for us, and of course we really appreciate Jim still continuing to come every Friday. The youth really, really appreciate it. And of course, we appreciate the support. But I think that would be all, unless anyone has any questions.
You have to talk about what's cool and unique about the new building because you guys put so much work into that and Healthcare Authority helped fund it. Yeah, it's really special. Please talk about that a little bit.
Absolutely, Jim. So the new building has a ADA unit. And so we do get a lot of phone calls, and unfortunately, the current house that we have, the rooms are in the second floor. And so we finally have an ADA room available, and we will be able to expand our services to the community.
Yeah, well, we do know there, and we just heard some of it, that young people on the streets who are trying to break away, many of them do have physical challenges. And this new building's got doorways for wheelchairs, a ramp. Like it's just so awesome that you can take anybody who wants to be there now. And I just have to say, I really love the group. I've loved getting to know the young people, but I've also loved seeing and feeling the culture that you guys have established in that home. It does feel like what we envisioned. It's safe. It's got warmth to it. It's not overly clinical, and yet there's a lot of clinical expertise. And we'll have to find another time because three of them were at work last Friday. So, well done to you guys.
Thank you.
Any other questions for Blanca? Um, yes, MJ, that is the one. MJ had a question in the chat. There was two of them that we got to go see. All right, if there are no other questions, I'm actually going to pass the meeting to you, MJ, for your introduction for the next segment. Thank you so much, Blanca, and I love hearing these updates.
Yeah, hello everyone. I remember seeing one of the ADA rooms. Unfortunately, I wasn't able to see the second house. Just remember seeing the first one. But yeah, no, I was gonna welcome here Dylan Ramirez, if not another person, depending on everything else. So yeah.
And that's with the Spokane Excelsior 1929 house. Dylan, yep, Dylan, you're up. Dylan, I think something's going on with your audio. And I also see Maleka right next to on the screen too. So if we need to
Is
pivot over.
everybody, are you able to hear me now?
Yes, there we go.
Perfect. Sorry about that technical difficulties. I had to restart everything. Thank you, MJ, for the introduction, and hello, everybody. I hope everyone's doing well this afternoon. So yeah, we're over in Spokane, doing really well. We've had some really good interactions. We have two more residents, and we have another referral that just came into us from Stars. We've been working with ABHS for one of the current individuals that are in the program, and then also with SRSC, that's also in Spokane. So been doing some coordination with them, and from both of the current residents. They've have some really good goals in place right now. We're supporting them with resume building, since we have our primary care right across the lawn from where the bridge house is, getting them set up with that as well, supporting them with any med management needs they are having. And yeah, so I'm just going out and doing a lot of outreach right now, like I said, trying to continue yeah, sorry, just trying to continue to reach out to all the community resources and attend everything that we can. I'm going to be attending the Impact over at Pacific Sky as well, once again to see their place, and very excited to continue moving forward in this. And I'm going to pass it over to Maleka, who is our care coordinator, to give some updates about what she's been doing with the individuals as well.
Thank you, Dylan. Dylan said most of it, honestly. But what I've been working on with our our newest resident is connecting her to the InReach program at Volunteers of America. She's got some housing goals and a goal to find a job. So she's interested in and really any entry level position, and I'm working with her to find either a cashier's job or a front desk job. Um, and I'm trying to think of the other thing that um, she already took initiative to find out about our GED programs in Spokane and had an orientation today with one of the programs to start working on her GED. So we're really excited about that. And then our other resident is looking for work as well, and he has a connection to Pioneer Human Services, is really interested in becoming a peer support himself, and then is looking into some general work at like fast food places and things like that. And his a few interviews set up. So we're really excited for them on their journey and continue to support them in those efforts. That's all I've got. Any questions for us?
I just want to say I'm so happy to hear that STARS is doing some referrals because I know we're going to have Ryan, the ED of STARS, come next month and present. And so I'm glad there's that connection that's starting to build up. And again, I want to thank the Spokane County because I think they're doing some referral stuff as well. So really happy to hear referrals are starting to come on board.
Yeah, absolutely. Thank you.
Yeah, thanks. Well, I also want to say thank you. Now that session's over, I'm going to be a frequent flyer over there to Spokane. So I'm eager to come by the program and see you all with Sarah. I want to also say, and since we have a little extra time, none of this happens without legislative champions and support. And we've had some really awesome ones from Rep. Cortez, who sponsored 1929, and Rep. Callan and Macri, and so many. But also, we're fortunate today to have Representative Lauren Davis, who really is a champion in the recovery field. And is helping us get connected to some of the recovery houses, which is still going to be I think a resource that's going to bloom right in front of us, especially now that session's over. We can all kind of get back to that. Many of the young people in the group talk about wanting to be in recovery, and yet, as is 100% normal, conflicted about, does that mean forever? So anyway, that's its whole work. But I want to welcome Representative Lauren Davis, since we have a little bit of time, and she's been a champion with this work. She's someone in the legislature that I can always kind of go to and say, hey, this thing's in trouble. Can you look at it? So I think it's important to be grateful to those who do the work for us in rooms that we aren't in. So, Representative Davis, please take a few minutes and just whatever you want to say, but please know how much gratitude we have for you.
Oh, sure. Yeah, no, thank you, Jim, and thank you to all of you for the work that you're doing. It's really exciting. It's obviously been a long time coming to get these two programs launched on the east and west side. So super exciting. I don't know that I have anything specific to share. I mean, I'm glad we were able to preserve the funding. We'd love to talk about expansion down the line. I guess, Jim, you had mentioned um, that it'd be great if we could sort of increase utilization of the two programs that we currently have. I mean, I might be interested in hearing a little bit more about numbers and where referrals are coming from and where referrals aren't coming from, because I'm certainly in a lot of places and spaces where I could help stir the pot to try to make sure that we're I mean, I think objectively anyone would think that these facilities would have been filled overnight, and obviously that's never true with a new program. But I do want to make sure that the word is out on the street, both for referrals into the program, and then yes, Jim and I have been in conversation for a long time about referrals out of the program into like Oxford House or recovery housing accredited by the Washington Alliance for Quality Recovery Residences.
Great. Maleka and Blanca, you want to take a minute to talk about where your referrals are coming? And I know Sarah's been working, we've all been working, but what the strategies are to kind of increase the pipeline of referrals?
So I think the majority of our referrals have come from substance use inpatient providers. We had one referral that was a behavioral health primary or need. I think, and so we're getting a lot of referrals from inpatient or getting our referrals from in substance use inpatient facilities. What we're not getting them from is like our stabilization and crisis centers. In the Northwest Behavioral Health, we haven't seen any referrals from them yet. Trying to think of who else. So that's
And
so
those
far
are
what we're
mostly
noticing.
psychiatric those are mostly psychiatric and mental health
Correct.
sources, right? So yeah, that's good to know.
And have you guys sort of done the circuit of, so not all, but many of the operators of inpatient psych in particular and crisis stay facilities belong to the Washington Council for Behavioral Health. So I don't know if there's been an effort to get them to push it out to their membership. And then the sort of trade association for inpatient SUD is the Association of Alcoholism and Addiction Programs, or AAP. So I don't know if there's been an effort to try to have them sort of send information out to their listservs. There's also like the Washington Council for Behavioral Health has their annual conference in June in Kennewick. So, potentially like tabling at a conference like that, that could be another idea.
Thank you. No, to be honest, I haven't heard of those councils before. So if you could type those into the chat for us so we can jot those down, that
Yep.
would be super helpful.
Yeah, and I'll try to grab real quick the actual contact information for actual humans there.
Thank you.
Blanca, anything to add?
Yeah, absolutely. We've been getting most of the referrals from the behavioral health hospitals, different inpatients. I think I want to say I was briefly taking a look at the referrals, maybe over 20 different inpatient facilities that have reached out to us. We also get referrals sometimes from the youth directly or the young adults directly, or maybe community partners that they're working with, such as DCYF, the YARD team, right there would be the most common ones, but also other organizations. One thing that we have noticed though is that the young adults are also telling their friends. So when we get youth or young adults referring or calling the program, it's, we'll ask them and, oh, I have a friend that did the program or has heard of it through a friend. So it's really nice for them to also be supporting each other.
Well, I have to say that, and I'll give this back to you, Sarah. Thank you for letting us kind of bust in here. But I just want to say that's the vision, because when we wrote the original report in 2018, and I talked to a bunch of outreach workers, I want to remind this group that what I heard from several is we don't refer to inpatient anymore because the young people go there. The word on the streets is, oh, so and so, Jim went to inpatient. And then they discharge him right back here. And so it was so demoralizing to both the staff, the outreach workers, and young people. So part of what we want to reverse is we want the word on the street. And if young people are referring, that's how it happens, to say, if you want off the street, if you want out of homelessness, go get inpatient and then get in this program called the Bridge. Because I know the people who did that, and now they have a life, they have an apartment, they have a job. I think that's really what we want, and I'm so glad to hear that. And then I just want to remind us, when we say behavioral health, it's so confusing, but we are talking about both substance use disorder and psychiatric mental illness. And in running the group, there are what we all know. Most of the young people do have what we used to call co-occurring issues, like they have both. Some mental health issues, whether it's depression and anxiety, plus the substance use or the addiction issues. But we had a group where young people talked about, even if I get clean, now I have to take this medicine the rest of my life in order not to have a manic episode or a psychotic break. So these are big commitments that young people are making. So there you go. Thank you. Anything else, Rep Davis, you want to say before we move on? And thank you, Blanca and Maleka and Dylan, very much.
No, I think that's it. I mean, the only other thing would be, maybe making a connection with the Washington Recovery Helpline. They're a statewide 24/7 resource that is paid for by the state. They're operated out of Crisis Connections, but I'm just trying to think about like who are the sort of referral sources, right? So those are some top ones that come to mind. And it's not, they can't be referred directly out of jail, right, Jim? It's only out of inpatient behavioral health.
out of inpatient or 30 days, within 30 days of being discharged from inpatient.
Okay, got it.
They can self-refer from a jail, but they can't be court ordered there. They have to be voluntary.
Oh yeah, but okay, but they could come straight from a jail.
The law doesn't preclude that. Really what we wanted to make sure is that judges were not making people to go there. And so then we had
No,
a house full of young people that were saying, I don't even want to be here. The judge made me come. It's like, no,
no,
we want,
a
well,
judge can't. Pre-trial,
yeah,
a judge can't legally order a person to do anything. But if you want to open yourself up to jail referrals, I mean, to be clear, like the
yeah,
people, if you look at crime data, it's overwhelmingly males ages 18 to 24. That's who commits crime in general, right? So that's who's in the jails. And so if you want to provide an opportunity for people, I mean, you have to come up with some, obviously, I'm sure you have admission criteria related to recovery readiness and things like that. But like, I work super closely with the jail commanders. We have 56 jails in the state, and they would
yeah.
be delighted to refer people your way. But I don't want to overwhelm the pipeline either.
I think we'll wait and see if we can really get the inpatients because then yeah. But Shannon's correct. The law doesn't preclude it. But I think for what the vision of the house is, I want them to get good at supporting those coming from inpatient and then take on others as
Hmm.
they get that pipeline nurtured.
Sure. Yeah, I would just
Great.
and again, I'll try to find it real quick. But I would also, in addition to reaching out to the kind of umbrella industry associations, potentially doing individual outreaches to the facilities, right? Like Harborview's got a bunch of psych
Yeah.
units, Fairfax, Smoky Point, like all of these facilities operate and, obviously have people in that age demographic.
Yeah, I'll jump in there
Yeah.
really quick.
And Harborview has referred. Go ahead, Johnny. You got the microphone.
Uh-huh. Yeah, I think that actually Harborview has referred, and I think also Bridgepoint and probably the other program are good programs for people on EHM, and then these programs would have to be able to talk about whether or not electronic home monitoring was a good option, and then you need an advocate that's with that young person, or a lot of times people are going to jail detoxing, getting on medication. They're there 30, 40, 50, 60, 70 days, whatever, may be released on electronic home monitoring. So they need an advocate to sort of work with them in making this an option. But there are many young people that would fit that option. And so I think just the housing programs thinking about having someone on electronic home monitoring, or if they have already had one, that would be very valuable.
Yeah, Bridgepoint has had one. Bridgepoint's got one that he just got his jewelry removed.
Yeah, so that's a huge thing. That's a big deal.
I
All
actually,
right. Thank you, Sarah. Go ahead.
yeah, no, thank you. I think this is such good conversations and I'm really glad and thank you. And Shannon, do you want to, there's just some stuff going on in the chat. Do you want to say anything about what you're talking about in the chat for those who don't know? Just because I do think it's also really good information. Not to put you on the spot, Shannon, but we do have a little bit of time. So if you want to come off mute and briefly talk about what you're putting in there, that would be great.
Yes, my pleasure. Thanks, Sarah, for the opportunity. So I'm Shannon Quinn. I work at DCYF and I serve as the Youth and Young Adult Housing Response Team Manager. And so we are also a legislatively created team through House Bill 1905. And so we work with young people who are 12 through 24 years old who are exiting publicly funded systems of care, which includes the behavioral health system, but is not limited to the behavioral health system. So we also take young folks when they're being referred from juvenile detention or adult jail or the prison system or JR. They can also be coming from the homeless response system, or they can be exiting the extended foster care or foster care system. So we are happy to take referrals for young people who are housing unstable or facing homelessness. We don't have a physical location the way that the bridge programs do. So we partner with Blanca and Maleka, and we partner to make sure that people are finding a physical place to go. But in terms of resource navigation and support from state agencies, we're here to help support people and break down barriers and open up opportunities for these young people and also track data so that we can report that back to the legislature and let you all know how things are going and where additional supports are needed.
Please
If I
repeat.
just ask a
Yeah.
quick follow-up, if that's okay. Um, so no, that's great. Thank you, Shannon. Yes, I'm now remembering the bill. I guess I just didn't remember that folks exiting carceral facilities were included. Have you ever presented to the jail commanders? The Washington Association of Sheriffs and Police Chiefs has a jail commanders meeting bi-weekly.
No, I've never had the opportunity,
Okay.
but I would love
I would
to.
like to make your acquaintance. Can you drop your email in the chat and I'll introduce you to Rick Bishop, who runs those calls? I think they would be very happy to send people your way. In fact, my own jail commander in Linwood would be very happy to send people your way.
Yes, that would be excellent. I'll put my contact information in the chat. Thank you so much, Rep Davis.
Great, thank you.
Great. And again,
And that's why we come together as a community, right
exactly.
there in line. Thank you, Shannon.
Yeah, I was going to echo that and just say thank you to Shannon too, and that team that's been working so closely with the bridge providers. So it worked out really well that actually we didn't have our HCA presentation because we've had to have a lot of really great conversations. And with that, actually, we are coming to the the end of our meeting. So Jim, if you have any last closing comments, or any other before Jim, if anybody has any comments or questions or anything else we want to talk about, we do have a couple more minutes.
Yeah, well, I'll give a little bit of a legislative update and the impact on Bridge, but yeah, we do have a minute. Is there anybody, just for the good of the order, you want to share something that will benefit this community, this conversation? This is where I often say in group, if you want to watch, you got to buy a ticket. That's a nice way of inviting folks. Don't be shy. If you got something, a program's opening, or anything you want to say, please put it out there. All right. Well, as we know, the legislative session concluded. And I think the sort of the big picture response or item was the budget, of course, and the Millionaire Plus tax. It's called the Millionaire tax. I think it should be the Millionaire Plus tax because it taxes after your first $1 million on your salary. So if you make $1,100,000, it's only the $100 that's being taxed. But that was a big thing, I think, and I think a step towards looking at Washington's regressive tax structure, which people have worked on for years and talked about for years, and this legislature did something about that. I will say, in terms of items that relate to this group, and again, if you have something when I'm done, feel free to contribute to that or add it. But we did get Bill 5957 passed, which, as chair of the Office of Homeless Youth Advisory Committee, this was our priority to expand that advisory group by 4 members, 2 that are 25 and over, and then 2 at large, so that we can add individuals who have disabilities or more parents, or just like who would help us when we ask the question, who else needs to be at this table? We have 2 at-large seats now. So, that was not a big bill in terms of having a fiscal note, but it's a big bill to us. And we're grateful to Senator Tina Orwell and Representative Jake Fife for being our champions. And we got that through. And, I should have brought a picture. We had a wonderful bill signing last week. And the governor was very delightful and expressed his commitment to our issues. Another bill that's really important here is 5911. And thank you to the Partners for Our Children and others. NorthStar played a small role. But this is the bill, you may or may not know this, but young people who are in foster care, if they are eligible for Social Security insurance money, either because of survivor benefits or some disability, the state, and not just Washington, across the country, the states have been taking that money and putting it towards paying for the cost of foster care. When I started Mockingbird Society 20 plus years ago, this was one of the first issues we picked up and didn't make much progress because it's a lot of money. Currently, for the state of Washington, it's $11.5 million that they take from children and adolescents in foster care to pay for their own foster care. So that 5911 made a very small, modest step towards that. And I will say DCYF has been supportive of this bill. I think everybody agrees on the policy. It's more of how do we find $11.5 million to start paying for foster care instead of taking it from children and adolescents. But 5911 starts that process with those young adults who are in extended foster care. So if you're in extended foster care and you're eligible for Social Security, you will start getting that money. And I don't remember exactly, but it's got a delayed implementation of a year or so. So this was one where the legislature was really in partnership. Again, I want to stress this. DCYF is supporting this, which we're so appreciative of. And they have been since it came up recently. So it's a big step to get that done, a modest step, but at least moves in that direction. I'm happy to say that the bridge housing was saved and preserved, so it's completely funded for this biennium. And we expect that to go forward. The Bridge Coalition did not get funded. We were in the Senate budget and the governor's budget, but not in the House. And the House had kind of made an arrangement or a rule, I think, of their own self-imposed rule that given they were cutting some beds, it was hard for them to fund coalitions. So, and I was even asked, would you rather have the bridge housing funded or the bridge coalition, which was a fair but kind of tricky question, given the bridge housing is beds and close to a $3 million price tag. And the bridge coalition is much, much less than that. So, but I'm happy to say, although we weren't in the budget, we've already heard from our partners at Healthcare Authority, and they are looking for money to help keep it going. I want to tell this group if we don't get any money. So what the impact is we were cut for fiscal year 2027, which starts July 1 of this year. So we will not be getting, NorthStar will not get any funding July 1 going forward. But we talked as a team, and we're committed to this work. We'll continue to run the coalition. We'll absorb the costs. And then we'll just see what comes from Healthcare Authority or whatever. But we also wanted to say, and we're going to lean on you for this, how can we improve the coalition? What's working? What should we preserve? We want to take this as an opportunity to look at our work and really not just get freaked out because the money's gone, but rather, what are we doing that's of value to the community? And how do we strengthen that? And what else can we be doing at this table? And again, I think we saw it today where we had this spontaneous conversation that all of a sudden the chat's blowing up with resources and connections. So that's really what this table is about. So we'll continue with the Bridge Coalition, and we'll be asking you all for ideas on how to strengthen it, improve it, topic areas. Sarah and the young people have done a terrific job, I think. So, yeah, anybody will have anything else they want to say for the good of the order, and I'll turn it back to Sarah. But please, if you have something you want to say, come off mute and participate. MJ.
Hello, hello everyone. Yeah, just to echo the chat conversations and whatnot. I did see the one with Birdpoint last year, and it was really really cool. And like looking at some of Excelsior's and stuff, I just was curious. Is there the photo of the second house? Because I was just like kind of curious what that would look like. I know they said that they were similar, but I just wanted to see what that looked like.
Blanca, I think that is directed to you. Did you, sorry, I don't know, I didn't see that in the chat, but Blanca, do you guys have photos of both houses that you could share out with the group?
Uh, yes, actually, I do have a couple photos. Just the outside. We do have pictures of the inside, possibly for the other house. I might be able to drop right here.
Awesome. And these are like no, obviously there's no clients or anybody in them.
Can you see that? Can you
No,
see it
not.
very well? Is it? I can't.
Oh,
Not very
there
clear.
we go. Nope. Almost.
Yeah, a picture of the governor and my grandchildren who were able to join us for the bill signing. I'll send it out. I didn't know if everyone wanted to be beat up, but that was the bill signing. And to prove I have some self-discipline, I'm going on mute and I'll leave the rest to you, Sarah.
That clap was not for that. I started that before. Jim, you're great. And I actually will I'll send out some of the pictures. I and Blanc, if that's okay, because I think everybody would like to see that. And then Rep Davis, I just want to thank you for those contacts in the chat. I'm also, if it's okay, may share some of those out in our readout and notes because I think it's a really good opportunity for people to see all of the different inpatients and detox centers. And with that, I do want to highlight what we have planned for next meeting. We actually do have STARS, which is one of Spokane's largest residential inpatient facility. They do withdrawal management. They are mental health as well as substance use disorder. Ryan and I know each other and extensively talked also about the bridge housing. So I'm glad to see those referrals. But Ryan's going to come and he's got a unique presentation. He's going to come and talk about obviously STARS, but he also wants to, I think, present some of the day-to-day I don't want to say issues, but I want to say struggles and barriers that inpatient providers are also facing. So really having an open conversation and dialogue where we can learn from one another. So he's willing to do that. So that is not one you are going to want to miss. Also at that same meeting, we have Mayana, Sierra, and Jamel who are going to be doing the presentation that they gave to the Y for Y Youth Action Board under OHY. It is phenomenal. NorthStar, we've spearheaded a behavioral health young adult summit series, and we're doing 4 of them in partnership with Y for Y. And so we are going to also make sure we're bringing those presentations and suggestions for system partners here to the coalition. It's some of the most impactful presentations. I mean, you heard Sierra today, and again, I want to just give you the biggest shout out for being brave enough. But Sierra's going to share, as well as, like I said, Mayana and Jamel. So that'll be on neurodivergence and some suggestions for system partners and providers. So that's going to be April. And then I will follow back up with HCA because I would love to hear about foundational community support. I'm sure those of us here would as well. And so with that, we all have 10 minutes back. And I hope everybody has a really great month. Thanks so much.